So I'm going to review the new Difficult Airway Society guidelines on the exclusion of potential esophageal intubation when that is on the differential for the crashing patient. Previously, other guidelines alluded to this problem, but this is the first time they have released focused guidelines on this specific issue. Previous guidelines had themes of when in doubt, take it out, and no trace, wrong place. The theme with this particular guideline seems to be sustained exhaled CO2. So some of the methods referred to in this guideline may not be available at your institution. Use what you have available, but keep in mind that CO2 findings such as colorimetric changes are not always reliable, not nearly as reliable as quantitative methods. To verify that you have sustained exhale CO2, they state that you need all of the following. First, you need amplitude that rises during exhalation and falls during inspiration. 2, you need consistent or increasing amplitude over the last 7 breaths. 3, you need a peak amplitude that is greater than 1 kilopascal or 7.5 millimeters of mercury above baseline. And number 4, the reading has to make sense with the clinical condition. So if your patient is in cardiac arrest, whatever happens to be, it has to make sense with whatever their current clinical condition is. If all these are not present, it does not preclude tracheal placement of the tube. However, it does indicate there is a risk for esophageal intubation, at which point you probably need to explore a little bit further. If you check out the paper, you can see some of the images of what they consider acceptable quantitative tracings. I'll be sure to include a link in the bio. They also have free materials available on the Project Universal Airway website, as well as their Twitter account. They post some of these same images from this recently released guideline. So you can always post them up in your resuscitation bays or in the back of your trucks. In their new algorithm, if you answer no to any of these questions that I'm about to pose, they recommend you remove the tube and perform bag valve mask ventilation or extraglottic airway placement for ventilation purposes. So number 1, is removing the tube dangerous? I think this will be exceedingly rare in the emergency setting, for which this would be a yes to this question. I think that's typically reserved for other very limited instances where it would be dangerous to remove the tube. Number 2, is the oxygen saturation adequate? Number 3, have you excluded esophageal intubation using both revisualization methods and a secondary method such as fiber optic visualization, ultrasound, or ventilation? And number 4, after you've completed all these steps and checked your equipment, has sustained exhale CO2 been restored? So if you answered no to any of these questions, then they do recommend you pull the tube and start using a BVM or an extraglottic airway. There are some commonly used methods that they specifically state are not sufficient for excluding esophageal intubation, which include misting in the tube, chest rise and fall, lung or epigastric auscultation, or bougie holdup. Overall, I think this provides a good methodology for thinking your way through the crashing patient that may have an esophageal intubation. I would recommend you check it out. At a minimum, you can kind of scroll through and just take a look at some of the graphics where they have the algorithms, displayed in a very quick, easy to read manner.